So starting off, question for Peter Aldridge from Andy Walton. How can a Grenfell scale disaster be avoided if treatment is taking place in inappropriate locations? He goes on to give an example, such as within blocked corridors, and also with insufficient staff to manage a successful evacuation should a fire occur. Um, so, how can a Grenfell scale disaster be avoided when we know these things are happening? Essentially, is I think the question for yourself, Peter.
So in recognising the difficulties that this presents from a fire safety point of view, the Department of Health did issue some guidance to NHS organisations around surge plans that fire safety does need to be central to the decision making when trusts go into surge. So, for example, the type of patients that I would expect to be treated in surge areas would be patients of a lesser dependency who, from an evacuation point of view, would be more likely to be able to do something for themselves with little interaction from staff. But you can't get away from the fact that if you've got, it doesn't matter whether the 6 additional patients in your surge area are ambulant or not, the staff to patient ratio also needs to be reflected, as does that patient require oxygen. So the oxygen treatment should only take place in a primary clinical area. So the whole issue is around a pincer movement of moving those who are less dependent into the surge areas and making sure that your overall plan of going into surge also looks at putting additional staff within those areas. So there are tools that organisations can use when they go into surge, but I think overall every organisation recognises that it's far from ideal, and the issue is to solve the root cause of what causes the surge in the first place to take away the problem.
That's a really good answer. Thank you for that, Peter. I did there was no messing around with that question. Straight into the deep end, I suppose, wasn't it? How to avoid Grenfell-type disasters in hospitals. Next one, I'll move on to Elspeth. So this person's fairly blunt, shall I say. They've gone on to say, this guidance is a fairy tale. Surely no one can expect a care home or supported living scheme to have enough staff on premises to evacuate people safely in the event of a fire. So I guess it's more of an exclamation, really, that. I didn't know if you'd like to touch on that at all, Elspeth.
I'll point you back to the ongoing prosecution of Your Housing Limited. They are being prosecuted for the failure to have emergency arrangements. They went back to court in April to have all charges dismissed. Clearly, this hasn't happened. They're due back in court again. And the law is clear. It's a commercial decision. If you decide to have insufficient staff in place to effect an evacuation, then you risk, particularly if there's a fire, a subsequent prosecution. And that's the bottom line. And we are now entering a very different regulatory and enforcement environment. And I would suggest that the risks are much higher, both for whoever is personally making those decisions, as well as for the organisation, is the blunt answer.
Thank you for that, Elspeth. I'm not sure if it... Yeah. No, thank you for that. And it's a blunt question, a blunt answer. I suppose that's only fair. Moving on, a question for Stephen Wilson. What MOR is required during the occupied phase for existing hospital HRBs? And I guess we sort of touched on that in your presentation, but I didn't know if you wanted to touch on that again, Stephen.
Yes, so obviously within the existing HRBs for hospital healthcare, if you're going to be having works done on it, then you can rely on the PCPD, principal designer, principal contractor, to create and demonstrate that they do have one. But it is, according to what our interpretation is, that you have to have your own. Basically, unfortunately, the government hasn't created what one should look like. We've basically created our own, which is simply a a database of which we can store the observations, because observations that are going to come from individuals are probably going to be hairy and wary with any kind of observation that they might think qualifies. So you need to filter through the good and the bad to identify really what is genuine and what is not. So on that slide, there was the 23 questions that we have created as a questionnaire, so you could use those. But the actual methodology is down to every unique company. So we've done basically a database. We allowed the individuals to submit that by an app on the mobile phone, so it can come to the database. It gets reviewed. Then when generate a report, that report is just simply the questions with the answers of the observations. Submit this to the accountable person from our side to the client, and then discuss collectively whether it is an applicable observation, and then decide whether is that going to be then forwarded by the client or forwarded by the principal contractor. All I could say is that have evidence of one, and that is basically your tick box of proving that you've got the evidence in process, isn't it? I mean, structural failures and fires are the main elements that seem to be covered. So it's not in the likelihood of, and that's particularly worded particularly towards the construction phase of things. So I believe within the actual occupied state, you're probably not going to come across the aspect unless you genuinely do just have a fire that takes place, and that'll be an occasion then which then independent companies can help you define what should and what shouldn't be. Thing is, once you do have an observation, you've only got 10 days to submit it.
That's a very good point. Does a CQC, and I'll open this one up to the floor, I think it might be aimed at Peter, but does a CQC registered facility have to comply with the HTM fire safety guidance? Now, my initial thoughts would be yes, but I will hand it over to the experts. So over to you guys.
I would say yes, because if the CQC are regulating it, then and the residents within there fall within the regulated activities under the CQC, then I would say, I think it depends what level of care is given within the care homes, because there is, of course, the residential guide that supports the fire safety order, but it's whether or not there's going to be people within there, particularly if they are being treated under NHS requirements, but they're within the care home, of how acutely ill they are. And the residential care does cross-reference into the HTM.
No, it's a fair point, isn't it? I think it would depend on that facility, but we would always say if you're ever unsure, seek legal advice, so seek legal guidance, and they will be able to clear that up for your particular facility as to sort of what you should be following as well. So if you are unsure as to that, we would recommend sort of looking into that too. I think another one for yourself here, Peter, just whilst you're off of mute. So my trust has reported increased activity of mental health incidents within surgical wards where patients use manual core points to act as a diversion in order to release the doors in order to try and escape. Can you provide any good examples on how other trusts who have encountered this have resolved the issues? Maybe not examples, but perhaps some sort of instances or what you would look to do in that sort of instance, I suppose, Peter.
Yeah, it's a really interesting question, and on lots of levels, with also a remit for overseeing security. This mental health patients on acute wards create all sorts of different issues. In regard to the specific point about what can be done with call points, I always take into consideration the overall reason that the call point is on the ward and an acute ward versus the numbers of time that the patient whose mental health is more acute, whose medical condition is more acute than the mental health, and they end up on the ward with us. And I think there is an element of looking at it on a very risk-based approach as part of the overall care plan for that patient. And are there things that can be done on the fire alarm system that would, could you for a period of time, if the risk of that patient absconding and the safety of that patient is greater than the risk of fire at the time, could you make a local adjustment so it doesn't release the door? Could you temporarily isolate that call point with the right training for staff locally in terms of could you put a temporary call point at the nurses station that overrides the one at the door? I think there has to be a level of detail in the individual risk that versus the greater risk of just taking the call point out without considering what could be an unintended consequence of that. Could you put a screecher cover over it so you get an initial warning that that patient has wandered? Could you put the patient on a one-to-one bed watch that might be available so it stops them getting out the bed, or there's an early warning in the first place? I think it's a very individualistic care plan in that particular scenario.
No, I completely agree, and yeah, a really strong answer. Thank you for that, Peter. A similar question goes out to yourself, Elspeth, around sort of mental health, and they've said in regards to sort of violent mental health or sort of severe mental health patients who may refuse to evacuate or cooperate during evacuation. What sort of solution would you have to, one, sort of remove patients safely, to remain compliant within the law and legislation, so yeah, I guess sort of what are those two main points? They did go on to say sort of how can you come on point one if you're not clinically qualified as well, but what sort of would you recommend in that solution where you might have somebody who is opposed to leaving the premises for mental health reasons?
This is something we focus very much on, both for mental health and any neurodiversity, so dementia, as to how you approach evacuation planning. And very much it is, because it is a personal emergency evacuation plan, it depends on the individual. It's very much around looking at what their capabilities, what the challenges are, and also devising an emergency plan, testing and helping them to understand what they need to do. Because one of the big issues with any neurodiversity is that a neurodiverse person is just as likely to hide in an emergency rather than evacuate. So it's getting through those barriers, mainly by providing an evacuation plan, maybe pictorial, and actually practicing, testing, getting them to help to understand, and also that if they do leave the building, they don't return to it, because that is another action that often a neurodiverse person will do, because they don't recognize any danger. So they will try to return. So it's being aware of those issues at an assembly point, or when you're looking at neurodiverse and mental health.